Just a little bit about me, because I think it's important to talk about a few different specialties since you guys are just thinking maybe about medicine. That I have several different specialties. I went back and got training multiple times, and I first started out as a pediatrician. So I went back to pediatrics, did a 3-year residency, both outpatient and inpatient. ICU pediatric surgery is one of the rotations as well. And then I was seeing a lot of chronic conditions that I went on to go get a fellowship in integrative medicine and became board certified in that. So I could treat a lot of kids with chronic disease, but then I was seeing a lot of headaches and pain in kids. And so I went and got my medical acupuncture board certification, and then built a headache and pain center at a large academic medical center for kids. But I learned that there was a few biomechanical issues that were going on that really needed to be treated with osteopathic manipulative medicine. And so then I went back to residency and got a board certification in osteopathic neuromusculoskeletal medicine. So I'm mostly treating a lot of headache and pain with some chronic conditions. And so I'll kind of talk to you a little bit about that. And that's why we're going to approach ankle pain. We see a lot of sports injuries. We see a lot of chronic pain. I see a lot of headaches. This is something, one of the cases that you see is something that's very common. So you will probably use this even before you get to med school. So some of you were asking about what it's like. How do you actually diagnose someone? And really, a lot of what you're going to learn, especially in your 3rd year and 4th year as a medical student, is how to present a case. And you really want to gather all this data when you are seeing a patient, either in the clinic or on inpatient, the wards. And you want to start off with why they're here, what's their chief complaint or complaints, and then a description of what is going on surrounding that symptom or condition. And that's using, sometimes they use all these different acronyms. One is old carts, and it's the onset of the symptoms. So say it's pain, onset of the pain, when did the pain start, the location of the pain in the body, duration, how long has it been there? Is it acute? Did it just start a few days ago, or has it been going on for several years? How do they qualify that pain? Is it achy? Is it dull? Is it stabbing? And then alleviating and aggravating factors. Does rest, ice, heat help? Does movement worsen it? And then any radiation that is going on, like, for example, a disc herniation where you have pain going down the leg. And then timing and severity of the issue. So that's kind of what sums up a history of present illness. So that's kind of a lot of the meat of what you're going to be talking about with the family or the patient. And then you can kind of go into review of systems just to make sure you're not missing anything systemically that could be adding to their symptom. And then usually in clinical practice, a lot of the times your nurse or your assistant is going to get the past medical and surgical history, which you can always touch on. They'll also get the family history and the social history. And then you will be conducting a physical exam. So a full physical exam, the cases we're going to present, they're a little bit shorter. They're not going to do a full physical exam on each of the ankle pain cases. But we'll kind of talk about the key aspects of the physical exam that you'll need. And then the differential diagnosis. Note, this is where the medical student really has to hone in on, because this is what you guys are going to think about in terms of what the patient has if they have a particular symptom. So if the patient has ankle pain that we're going to talk about, what really could the diagnosis be? What could be going on underneath that symptom of ankle pain? And then you're going to come up with an assessment and plan. Are you just going to get a workup? Are you going to get imaging? Are you going to give pain control? Are you going to give rehab? And then you guys can come up with an outpatient care plan after they go home. So that's kind of the key aspects of how to present a case. And we'll go through this. The cases outline it, but we'll go ahead and get started. I'm going to switch over to the case. Okay. Oh, wait, hold on. Let me do this one more time. So I think I have to share my sound. Okay, good. All right. Okay, I'm going to go ahead and play the case. You guys might want to turn your volume up because sometimes the volume is a little bit low. And then I think is some language from the patient because I think he's in a lot of pain. So excuse that. But I'm going to go ahead and start this. Make sure you turn your volume up so you can hear it.
Good afternoon. Hi, I'm Dr. Moore. We're here at Yale New Haven Hospital. Thanks so much for taking the time to do this video.
Uh-huh.
You mind telling us again what happened, how you did this?
I snapped my ankle at work, and I gave these guys permission to do what they got to do.
All right, what were you doing? How did you snap the ankle?
I was, I don't know, I was walking around a corner real fast at work, and I just happened to roll my ankle over, and I looked up, and I seen my foot was facing
You just rolled it, huh? And then
Yeah, man. I
Now-
looked up, and it was rolled the other way, man.
so here's your right ankle.
Yeah, shit. Up here's starting to hurt too, man.
Yeah,
My
we're
leg,
gonna
man.
get you something for pain right away.
Thank you.
Okay, so
Thank you.
the ankle there. All right. And can you wiggle your toes? Are you able to wiggle your toes?
A little bit.
A little bit.
Yeah.
I'm just feeling the pulse. Try not to move it for a second.
Yeah.
So you've got palpable dorsal pedis pulse. You can feel it when I touch you?
Yeah, I can feel that, man. Oh,
Did you hurt anything else?
Nah, man.
Okay, all right.
It's
We're
just
going to
there.
get you some medicine for pain, and then we're going to put it back in place, okay?
It shit hurts, man.
Okay, so you guys did see that the ankle was pretty deformed. And this is a very unusual presentation for how he actually hurt it, but we'll get into that. Okay, so just a little bit more information to know about the patient because you really got a very, very short history of present illness, and we didn't get much in terms of past medical history. So he's male, he's 44. We don't have his weight or height right now. It looks like he is a little bit on the heavier side. His vitals look great. And then he had a fall. He twisted his ankle with a subsequent deformity and really significant pain. It looks like based on his history, he is has been an opioid abuser. So now he's on methadone. He's currently sober. And just as a heads up, a lot of these patients who have abused drugs or other substances in the past, sometimes they're actually more prone to having worse pain in the long run. So they'll have a lot of chronic pain symptoms because opioids, unfortunately, have this central sensitization that goes on and can cause chronic pain themselves, or actually worsen certain pain conditions if taken too long. So, Gianni, I think we can do our first one of the poll questions that's on the differential diagnosis poll question. All right, you guys can input what you guys think is going on. What is your differential diagnosis? Is it an ankle sprain, ankle fracture, ankle dislocation plus a fracture, just an ankle dislocation, and bone cancer? And I'll just wait a few minutes. All right, looks like we'll wrap up here in about 20 seconds. So it looks like ankle dislocation plus fracture is winning. Okay. So yeah, it likely is going to be an ankle dislocation and fracture. We'll get into this because typically it's such a forceful injury, though the way he injured it is not the usual mechanism of how you get an ankle dislocation. So he may have had some weakness or instability at that ankle already, because usually it takes a little bit more force. Ankle dislocations are much rarer compared to shoulder dislocations. So let me pull up Okay, so I just wanted to go over a little bit of the ankle anatomy with you today. So the ankle consists of a few bones. As you can see here, this is the tibia and this is the fibula. So these are your leg bones. And it sits on top of the talus. So the talus is this nice little bone. Here's the cushion underneath it that connects with your leg bones. And so this is the bone right here underneath the leg bones, the tibia and fibula, that actually got dislocated. And it looked like from the case that his talus looked like it was posterior. So these two bones were sticking out and that this bone was sticking behind back here. So it was a posterior dislocation. If the tibia and the fibula were back here, then the talus would be up here. That would be an anterior dislocation. Okay, so let's look at that again. I'm gonna pull back here.
Just feeling. Can you wiggle your toes? Are you able to wiggle your toes?
A little bit.
Yeah. Just feeling the pulse. Try not to move it for a second.
Yeah.
So you've got palpable dorsalis pedis pulse.
So you can see here's the tibia and behind is the fibula. And so the talus is tucked underneath them. So it's posterior back here. The physician is feeling, he's doing a neurovascular exam right now. And this is very, very important for dislocations because there can be a lot of shearing of a lot of the neurovascular areas around the ankle and the foot that can compromise blood flow and then also damage the nerves. And so that is more of an acute situation so he doesn't lose his foot. So it's very, very important to constantly do your neurovascular checks. Okay, so I think we can pull up one of the, oops, hold on, I can't. Okay, we got another poll for you guys. Okay, Janny, we can pull up the where is it? The likelihood of fracture question. Okay, how likely is a fracture with an ankle dislocation? You guys will probably answer this very quickly. Yeah. So, oops, sorry. So yes, the fracture, a fracture is very, very likely with an ankle dislocation, just because usually it requires a whole lot more force. This case is unusual. He really must have some connective tissue issue or hypermobility or ankle instability because just twisting it usually does not dislocate or fracture the ankle. So something else must have happened, or he didn't quite remember what happened. So we're going to look at the workup here in terms of what they did, and then we'll also ask another question. Okay, let's see. All right. So the patient workup, obviously history and physical exam, we'll look at sort of the neurovascular supply to the foot, but they also should do an x-ray. Now, when why don't we do this actually first? Let's do the video of the ankle reduction.
Okay.
Okay,
All right,
we're
here
doing
we
a
are.
timeout.
Yeah, you want to take us through this?
Sounds good. So, on our timeout, this is Leonard Anderson, date of birth 6/18/1978. We're performing a closed reduction of a right ankle dislocation. Okay, we have No imaging addressed because there's gross deformity. We have our meds on board, which include etomidate.
Bitch, that's you.
Meds are not on board yet. We're about to give them.
He's pre-oxygenated at 2 liters per minute
right
via
now,
nasal
bro.
cannula. He's on capnography. We've addressed all other types of medications, including his methadone. He's received a total of 200 micrograms of fentanyl IM and 150 micrograms of fentanyl IV. Is everyone in agreement?
Let's go, man. Let's get this shit on the roll, man.
Okay,
Please.
suction is ready.
Let's get it, man.
Good oxygen
Suction
saturation.
is ready.
Get it in. Let's go.
How much do we have here?
12 milligrams of etomidate.
Okay, we're gonna give 7.
Oh, you want it only 7?
Yep.
You want 19 over there? I can still do math.
Yeah.
I can still do my math.
7.
Oh, please, just put me knocked out, man. I want to be knocked out, man. I want to feel this thing, man. Please. I do not want to feel this
Okay,
shit.
7
7.
milligrams of etomidate.
Let's go. Pushing.
Alright.
We're pushing.
All right, so
Oh, don't touch it yet, please. Don't
7
hit
milligrams
that
going
yet,
in?
man. That's just going to hurt me, man.
okay, wait, get it.
Please don't do that yet, man.
Etomidate
I
going
want to
in.
feel this shit, man.
All right.
I want to feel
Just
nothing,
get
man.
Philly speed. All
This
right,
is
so what
gonna
we're gonna
hurt.
do is,
I don't want to feel this shit, man.
all right. Can you do me a favor?
I just want to feel nothing.
I know. Can you do me a favor?
Yeah.
Can you start from 30 and count back slowly? Okay. All right, looks like he's going out. All right. So now we're gonna pull on this ankle and distract and put it back in place. A nice, strong, gentle pull. All right. You got it back in?
I got it back in.
Okay. Good. Nice job. All right. Are you still sort of with us? We just checked the O2 set. Okay.
Okay, let's watch that again because it's a very quick reduction of that dislocation. Let me see right there. Okay.
He's going out. All right, so now we're going to pull on this ankle and distract and put it back in place. A nice, strong, gentle pull. All right, you got it back in?
I got it back in.
Okay, good.
So usually you'll have to do for dislocations a lot of traction. Traction is definitely key. And so that's why he was pulling on that foot toward him so that he can disengage that talus and then really get that back into place. It just comes back in. Usually all the muscles and the tissues are really all spasmed surrounding it. Okay, so then the post-procedure exam, let's take a look.
All right, how we doing? You're on video again here.
We're doing great, Doc.
How you feeling?
I feel a lot better.
Better?
I'll tell you that right now.
All right, it looks like
Is it bruised up right? I see black and blue.
a little bit. We got to get the x-rays. There might be a fracture still, but
I think so.
yeah.
I believe there is. Because
Do you remember us putting that back in?
Yeah. I didn't feel it, though.
You didn't feel it?
That's a good fuck. That was a good thing.
That was a good thing.
Only thing I felt was just a little pop, and that was it. But
Yeah.
other than that,
Good, good. All right.
pain medication, it
Yeah.
worked excellent.
All right, excellent. Good to hear. And
Thank
we'll,
you guys.
we'll get the x-rays and we'll check back, okay?
Okay, and then here's the post-reduction x-ray. So you can tell right here is a fracture, the fibula fracture. I don't know how he knew it was fractured because let's pull up the other poll question on the pre-procedural diagnostic question, Janny. Oh, maybe. Janny, are you there?
Yeah, I lost you for a second. Repeat
Oh,
that.
okay. Yeah. Do you mind pulling up that procedural diagnostic question? All right. What pre-procedural diagnostic workup is missing from this case? We have the post-procedural workup, but we don't have what? All right, I'm gonna end the poll here in about 10 seconds. Get your answers in. Okay, I am gonna wrap it up, share results. Yeah, so ankle x-ray. So we do need a pre-procedural ankle x-ray because typically, usually if there was an orthopedic surgeon on hand, they would likely be facilitating the reduction if there was a fracture involved. And so Miguel, you just had a question to be sure whether or not there might be a fracture present in a dislocation. Would an x-ray be needed? Also, when analyzing the x-ray, is it easy to see the fracture? Yeah, so definitely need a pre-procedural x-ray and a post-procedural x-ray. So we have to look pre and post because things can change when you reduce it. So there can be an osteochondral defect after reduction. There can be issues like even a worsening fracture, even bone shards if there was a different type of fracture than what was seen on today's case. So yes, I had imagined they did it. That's how he knew he probably had a fracture, but I'm not sure what happened there. Okay, so I'm going to share the rest of my PowerPoint and we'll walk through a couple things and then go on to the next case if no one else has any other questions. Okay, so we looked at the talus. Now, if you can see here, this is all the neurovascular supply that is going on. So blue are veins, red are arteries, yellow, orangish is nerves, green are lymph. And so there is all this shearing force that it can cut through arteries and veins with such a bad dislocation that this guy had. And so that's why looking at the neurovascular system is really, really important on the physical exam. So here, based on Miguel's question, just wondering how easy it is to see. It just depends on the patient. It could be very, very difficult. It could be a very small fracture. Usually that's why we have radiology read the reports and also other, like even the ER doc would have looked at the actual imaging of the x-ray, and that's why the orthopedic surgeon. So we've got like 3 people, at least 3 different specialists looking at the x-ray to make sure there isn't or is a fracture. And here, if you look on a lateral x-ray, this isn't his, but here you can see this is a very big fracture, easy to see. And this is a posterior dislocation of the talus here. It's more difficult to see on the anterior posterior view, but you can see the fibular fracture right here. So yeah, it's just practicing looking at a lot of images, and you guys will get that in med school, especially in your anatomy class. Here is a dislocation without a fracture. Obviously, it's way easier to see on a lateral x-ray. You can see this whole bone is just shifted backwards where the tibia and the fibula are above it. It's a little bit more difficult to see on the anterior posterior view, but you can tell this really should be shifted up in this nice little area right here. So the radiologist would be able to tell that that was a dislocation. So ankle dislocations with a fracture, like I said, orthopedic surgery typically needs to be consulted right away. They usually do the reduction with sedation. I don't know anything about what was going on in that particular case. They're just trying to teach the actual symptomatology, differential, and then workup. And then simple ankle dislocations without a fracture, yeah, it can be easily done typically by a general provider, ER physician, family doc, pediatrician, usually with sedation just because it is so painful. Obviously, if you're out in the wilderness and need to do it, then, you know, have them bite down on something, do it very quick. Okay, so obviously we need to make sure we have a plan in place for post dislocation and fracture management because the tissue surrounding that ankle joint becomes so inflamed and damaged, it causes significant weakness, pain, which causes future arthritis when they have a lot of the damaged tissues. And then one of the big things is the strength and balance issues. Their proprioception is just completely off because the fascia, all that tissue surrounding that ankle joint, those bones, are really what help us balance and make sure that we have normal gait mechanics. And so when that gets thrown off, everything else can get thrown off. It can go all the way up to your knee. It can create a lot of knee pain problems, future meniscal tears, knee osteoarthritis can go all the way up to the hip, which causes hip osteoarthritis, muscle imbalances. So very important to get this taken care of, which any type of ankle dislocation, any type of leg or ankle or foot fracture, really we need to provide rehab, which is going to be physical therapy to both strengthen and then provide that balance or proprioceptive training. And then also making sure the tissues and the alignment, the muscles, joints, nerves, everything surrounding that ankle joint and above is balanced and aligned, as well as any fascial disruptions are taken care of. And that's through osteopathic manipulative medicine treatments. And so I do a lot of that right now. Though I'm an MD, I did go back to residency for it. So there is a difference between different medical schools, the doctors of osteopathy versus the doctors of medicine. And so you get that extra rehab training, especially for ankle pain, if you're a doctor of osteopathy. Okay, if we have questions, let me see, before we move on to the next case. Okay, so we have a question about the patient seemed to be a tiny bit difficult at first because he was in a lot of pain, but then, he did just fine after the reduction and was very thankful. So what if he were more expressive with this, like he was yelling and he was a little bit more violent, maybe more physical? What kind of training do healthcare workers receive to deal with this, if any? And is this learned from more and more exposure and practice in clinical settings? Yeah, so this happens all the time. There are going to be patients that do yell and that may be more violent. And so that's when usually security is called, especially if it gets a little bit more expressive. And also physical. And so security, especially at a medical center or a hospital, or even just calling 911 if needed. But you do get a lot of exposure, especially in emergency medicine, to this type of behavior. So yes, you would get training more on the job typically, but there are processes that every clinic and every hospital has. Okay, so I'm going to answer another question. Would laboratories have been done prior to reduction? What kind of labs? This may have been done if the patient had some kind of systemic disease process that would be a complication to the reduction. So say if he had some kind of chronic kidney disease or chronic liver disease, and he would be potentially sensitive or have some interactions with the drugs that were given for sedation, then that would definitely be done. Typically, though, not for just a general healthy patient getting an ankle reduction. Okay, we got another question. What if you miss a fracture that a patient has? Also, when do you decide to order an X-ray versus an MRI or CT scan for an ankle injury, unless you see an X-ray being ordered, or usually you see an X-ray being ordered? Yes. So what if you miss a fracture? Yeah. Doctors, we are not perfect. We're all human. We're going to make mistakes. If a fracture is missed, usually the patient, if they get sent home, they're going to have continued pain and they'll have always follow-up. So they'll usually have a post-ER or post-hospital follow-up with their primary care doc. If they're having worse pain or continued pain, then maybe potentially another X-ray is going to be ordered and they'll go back to the hospital or to the orthopedic surgeon to get that taken care of. It'll just be delayed care, typically for that type of patient. And when you decide to order an X-ray or an MRI or CT, so X-rays are usually looking at bony abnormalities or osseous abnormalities. It doesn't really get into the soft tissue. So we were not able to see what ligaments or what tissues were torn in his ankle. And so that's when an MRI would be ordered. CT might be more for like if the orthopedic surgeon needed a real specific anatomy, he needed to look at more specific anatomy, he'd get a CT scan of the bones because the CT generally looks at the bones just a little bit more than the MRI. The MRIs are getting really good now, so some of them can take a look at the bones perfectly. Let's see, another question. How would a twisted ankle look different from a Oh, yes. Well, we're gonna look at that next. Good question. Okay. Fred, how can you be sure none of the nerves, vessels, arteries, or lymph have been damaged? So we do a neurovascular exam, which consists of feeling for arterial pulses. There are several arterial pulses in the foot and the ankle. So we want to make sure the arteries look okay. Then the nerves, you're going to look at sensation. Are they having pins and needles? Are they having numbness? And then you are going to use different tools to evaluate that numbness around the foot. The veins and the lymph is a little bit more difficult, but usually that might present a little bit later where they're going to get some more swelling. And so that's when you know that some vessel or lymph have been damaged. And then you can always get imaging in the future if that's the case, like ultrasound and MRI. Okay, we got how long is the typical recovery time for different types of ankle injuries? Ankle dislocation with a fracture is probably going to be a while, usually might be in a cast, potentially for up to 6 weeks, and then even longer rehab. So it's the ankle dislocation and fracture, definitely a lot longer than an ankle sprain. And then the next one we'll get into once we present that case, but probably going to be in a cast for about 6 weeks or so, depending upon how bad the fracture was. Okay, and then Devin, yes, you can get a copy of the slides as long as you don't share them. Okay. All right, I'm going to start the next case here. Let me open it up. Okay. Okay. So, oh, and Anna, or Anna, is there a pattern between age and the frequency of occurrence of this injury? The ankle dislocation is so rare. I don't know the pattern. It's usually a trauma. It's more often something happens, and so it can happen at any age, to be honest. But if there has been previous issues that have happened to that ankle, like hypermobility disorders, a connective tissue disorder, previous fractures, previous multiple sprains, and they hadn't gotten rehabbed appropriately, then that ankle dislocation is going to be more likely. All right, so let's get started with a left ankle pain now.
Okay, we got a 70 years old a male patient. He came to the urgent care because of pain on his left ankle. Can you please tell me a little bit more about your ankle?
The only thing I can't move like my ankle, like my foot, I can't move it upwards or downwards. The only thing I can move is my toes, and at first I can walk a little, but after I start walking a lot, my leg starts hurting and I feel like a sharp pain on my ankle.
And can you tell me what happened?
I was jumping on the trampoline, and then that's when I stepped wrong, and then my ankle
You twisted?
Yeah.
Okay. Okay. Is there any numbness or tingling on in that area?
Yes, from time to time when I'm
Sometimes?
Yeah.
Okay. So thank you for sharing your case with us. And let me go ahead with the physical exam, okay?
Okay.
Thank you. Okay, we got a 17.
Okay, so he, I think he goes in the physical exam later, but what we've got is a 17-year-old male. He is, vital signs look stable. He twisted it on the trampoline. That is a common injury. And then he's got some ankle pain and edema, difficulty moving it. So that's limited range of motion for the ankle. And he's got some paresthesia, which really means some tingling off and on. And then he's got some point tenderness to that ankle, probably on the lateral side of that ankle. And he doesn't have any medical issues, social issues, nor is he on any medications. And so, Janny, if you can pull up the differential diagnosis question.
I think we already did that one. Anna.
Oh, does it go away?
Yes, it does.
Oh, okay. There was a duplicate and I think it must not have gotten transferred. Okay. Well, let me just double check here. Okay. Can you pull up the common way to sprain an ankle? Okay. So what is the most common way to sprain an ankle? Now, inversion is where your foot churns inward. So if you're looking down at your feet, your ankle churns inward. And then eversion is where your ankle churns outward to the side. So your foot is outward. So you guys may know this, even not even discussing it, just because it probably has happened to you at some point in time. All right, and we'll wrap up in about 15 seconds. Get your answers in. Yeah, all right, so I'm going to end poll. And then it looks like a majority got inversion. That is the most common, where you churn your ankle inward, and then that lateral side of your ankle, the outside of your ankle, is the one that gets really swollen and painful and injured, just because that's where you've really kind of spread or torn those ligaments because they got pulled to the other side when you sprain your ankle and invert it. Okay, so let's go back to the case. Okay, so differential, you guys pretty much had the same differential as it was on the last. Just any ankle pain, you want to be thinking about ankle sprain, ankle fracture. Elise Franck injury is a foot fracture. And so it's just sort of expanding your differential. Looking at the ankle dislocation, so subtalar dislocation, just like we had a high ankle sprain is, we'll go over this in just a minute, but this kid, they did their workup a little bit backward, but I'm going to show you a little bit about the ligaments around the ankle before we get into the patient workup. So if you look here, okay, so the most common is an inversion injury. That's when your ankle turns inward. And so then all these ligaments on the outside of your ankle, this is on the outside. So here's the fibula. So the fibula is that bone, that bony protrusion on the outside of your ankle. And the ligaments that connect it to the talus it's called an anterior talofibular ligament. And this is the most common ligamentous injury in an ankle sprain. So these get stretched. Both of these get stretched when this ankle goes inward. It's really not supposed to do that. And so these ligaments get relaxed, they get real distorted, they get torn, and And so that's what really is the cause of a lot of the pain, in addition to all the swelling that occurs around that ankle sprain. The calcaneofibular ligament is also from an inversion injury, so you can also have this ligament injured. And the calcaneofibular ligament, really, they're named after what bones they connect. So ligaments connect bone to bone. This is the calcaneus underneath, and here's the fibula. So it's a calcaneofibular ligament, and that's how they name them. The anterior tibiofibular ligament sprain, that's a high ankle sprain. That is a bigger injury. That's an external rotation injury. That's associated with a lot more issues. That's usually when they need to maybe potentially talk to orthopedics or sports medicine. Here is where there's a lot of ligaments where it connects that tibia and the fibula together. And so if you look at this, this is the tibiofibular ligament. And so this is a higher ankle sprain. These are lower. So that's why it's called a higher ankle sprain. And then a deltoid ligament, which this is less common. It still happens. It's an eversion injury. So here's your foot, and then the ankle goes outward. So that foot comes outward, and then the medial ligaments, there's a whole bunch of ligaments in here on the medial side of the foot. Here's the tibia, and then this is the one that gets stretched and torn on this side. Now, they didn't show this in the case, but anytime, just like you guys were asking in the questions, which are great questions, do we need an x-ray for this patient? Ankle sprains, they don't typically need an x-ray because we follow the Ottawa ankle rules. And these are rules that have been developed and validated to make sure there's really not a fracture. It's not right all the time, but it's a right majority of the time. That if in our physical exam, we palpated and felt for any bony tenderness along this medial side of the medial malleolus. So that medial malleolus is where that tibia comes down. If we palpate around here, there is no bony tenderness there. There's no bony tenderness at the base of the fifth metatarsal over here. And then there's no bony tenderness at this navicular bone right here, and they can bear weight at least for 4 steps, then they're good to go. They do not need an x-ray. So that Ottawa ankle rules really help us avoid excessive imaging. Okay, so let's go back to the case. Okay, I'm going to play this.
This is the physical exam of the patient. Can you bring this up?
No.
No, you have pain, right?
Yes.
Can you bring it downward?
No, it's the same thing.
The same thing. Is there any pain while I touch here? Just let me know.
Yes.
Pain, no? Okay. Do you feel this?
Yes, I can feel that.
You can feel that? What about here?
Yeah, I can feel that as well.
Okay, there is no change in the color, right? Okay. So basically, this is the ankle.
Okay. So then they just show pictures of sort of the ankle swelling. You can see all the ankle swelling. They typically do have a lot of bruising as well. You can kind of see some develop. The swelling is really what's probably causing a lot of the paresthesias or the tingling, just because it does sort of cut off a little bit of, put some pressure on the blood supply and the nerves. And so they just provided analgesia. They did get an ankle x-ray and an ankle MRI. It was likely that they didn't, but again, medicine is not perfect. No one does it just according to every single guideline because the patients don't always present that way. And so here is just a lateral view of the MRI that they got done, and it doesn't really show anything at all. This is just one picture. You usually look at a whole bunch of different slices of the MRI. And so the ultimate diagnosis is left ankle sprain. Now, let me switch. Okay, so for an ankle sprain, it is very, very important to make sure they have appropriate outpatient plan of care because you can have significant damage, again, both to the fascia, to the tissues, and to the alignment, which then progresses into arthritis and then poor muscle balances, which really leads to a lot of chronic conditions, and then decreased performance. So if you're a runner or if you're an athlete, you really need to do quite a bit of physical therapy and rehab. So pro-lice, I know everyone heard of rice, where it was like rest, ice, compression, and elevation. Well, recently they've done a study to do pro-lice instead because it has way more evidence. Rice really didn't have a lot of great evidence. It really didn't heal a ton of the ankle sprains. So pro-lice is protection. So you want to protect it. So you don't want to re-injure it. So you have to stabilize it because the ligaments are so lax, they're not holding that ankle joint, together as well as it was. So you can potentially sprain it very easily again. Rest, so that you are making sure you're doing optimal loading. So in terms of walking, in terms of exercising, because you do want to have some loading, but it has to be optimal for the healing. And that's where the physical therapist comes in. Ice is important to decrease the swelling, and then compression to help with some of that swelling to get it back up, because lymphatic drainage works from everything to the heart. So if it's down in the foot, you want to bring all that fluid back up to the heart, and compression potentially can bring that fluid, all that lymphatic fluid and vascular drainage back up to the heart. And then elevation, so that fluid gets out. We really need that fluid to get out of the foot. And then you want to do immediate osteopathic manipulative treatment. There's a lot of fascial techniques that we can do to help smooth out both the muscles, the tissues, and the ligaments in order to facilitate that proprioception, balance, and strengthening and aligning that joint again, as well as lymphatic techniques and making sure everything's aligned. Sometimes it gets thrown off just a little bit in terms of the joints. And then physical therapy, really focusing on that proprioception and balance. There's so many proprioceptors in that fascia of the ankle that when it gets disturbed, it gets thrown off. And so really need to do that for performance, as well as just, general movement. Okay, I think, let me just see here. And then we'll take questions. Okay, so let's pull up the last question, the chronic issues after ankle sprain question, and then we'll get into everyone's questions. Okay, what is the most common chronic issue after an ankle sprain? There is honestly no wrong answer to this, but I just wanted to see. All right, we'll give you guys about 20 more seconds. Okay. All right, I'm gonna go ahead and end poll. Yeah, so kind of across the board, a majority of, poor balance and proprioception, tendonitis, that can happen, chronic ligament laxity, paresthesias, that can happen, especially if the nerve just didn't get healed as well, or if there's still some lymph and some fluid still in that ankle, if it wasn't treated appropriately, typically needs some osteopathic manipulative treatment. But yeah, you guys got it. And I think we have time for any more questions. Okay, can I expand? Oops, let me get out of here. Oh, I just lost the question. Oh, there it is. Okay, can I expand on bony tenderness? How does it feel, or how you can tell? That's when you take your fingers and you push directly on that bone, on aspects of that bone, and it is very painful for the patient. It's not just a little bit of tenderness, it's usually painful. Usually if you push on the bone, it should not be painful at all. How long does a high ankle sprain typically take to heal? How do you know if there is something more serious going on? Well, with a high ankle sprain, usually you're gonna need more imaging. So X-ray plus an MRI image of the ankle. And it takes a little bit longer just because it's holding the tibia and the fibula together on top of the talus. And so it's at least 4 to 6 weeks. Another ankle sprain, it can get better if you do the right treatments as quickly as possible. So with osteopathic manipulative treatment, can get better within just a couple weeks. So, okay, let's see. Oh, okay. How long does, okay, got that. Okay. Can you explain optimal loading again? So yes, remember the protection rice, optimal loading, ice compression and elevation. So optimal loading, when it refers to an ankle sprain, it's just gradually applying some weight to that injured ankle to stimulate healing. Healing, it doesn't always occur just with rest. And so that's why we do, and that's why osteoporosis, we always recommend, jumping or strength training or really providing load because it actually heals the bones and the tissues. So that is also a little bit more protective. Doing that optimal loading, not too much and not too little, so that the tissues actually heal because it stimulates healing. So that's why strength training is really great. Are lymphatic drainage massages good to treat sprains? Yes, I would recommend lymphatic drainage massage. What kind of athlete do you see the most for ankle sprains or fractures? How does it usually happen? So soccer, football, basketball, futsal, anything on the gym court, just because it's so easy to plant your foot and then it gets really sticky and then you twist it. Miguel has a question on what is osteopathic manipulative medicine? Is it different from physical therapy? Yes. So osteopathic manipulative medicine is a practice of medicine that often doctors of osteopathy, so DO schools, those who graduate from DO schools can do. So you get many, many hours of training, and it's all about allowing the structure and function to improve and also heal both, not just the body, but also considering other holistic areas in terms of psychosocial, environment, spiritual, nutrition, and other aspects of health that are not often in just pharmaceutical medicine. How do comorbidities, diabetes, osteo affect your assessment of an ankle fracture or dislocation? Yeah, so people with diabetes have a little bit more difficulty with their microcirculation, and so they are not going to get as many healing substances to that ankle fracture or dislocation, so it can take longer. Osteoporosis, their fracture or dislocation can be way worse just because their bones can fracture much more easier. So it might be a bigger fracture with osteoporosis. So comorbidities are very important in the healing and recovery of an ankle fracture or a dislocation. Okay, for a patient with a history of recurrent ankle injuries, how would your treatment plan change? Also, if the patient's pain does not improve despite treatment, what's the next step? Recurrent ankle injuries typically does have to have quite a bit of physical therapy and osteopathic manipulative treatment, like I said. Now, recurrent ankle injuries, we want to make sure there's nothing else going on, like a hypermobility disorder, so might have to evaluate for something like Ehlers-Danlos syndrome or another connective tissue disorder where it can affect them to have recurrent ankle injuries. And then I don't hear a lot about schools of osteopathy. Why did you decide to go to med school versus a school of osteopathy? Well, my mentors, when I was much younger, they didn't know about osteopathy. And so a lot of my mentors were MDs. So no one in my circle knew anything about DOs, and I didn't actually know there was a school of osteopathy. I would have gone so I could get that extra anatomy and structure and function and skill to have. Would I recommend DO schools over MD schools given your experience with both types of medical training? Yeah, I am an associate professor. I've taught both at MD schools and now I teach at a DO school. I find that the DO school, since I've taught and done medical school at Doctors of Medicine, that they have a shortcoming of their clinical education. And so the DO schools are a little bit stronger in their medical education compared to MD schools. MD schools more focus on pharmaceuticals. And so they don't have that whole aspect of what medicine and healthcare truly is. And plus, you get a ton of skills, and your palpatory skills are way better at your physical exam skills when you do go to Doctor of Osteopathy school. There's no MD school that's in the top 15 or top 14 schools of the United States. It's all DO schools. You get a little bit more resource. Like you get to learn ultrasound, you get to learn a lot more clinical integration compared to MD schools. So, and then we're about to wrap up. We've got 2 more minutes. But 2 more questions. What's the most subtle or easily missed ankle fracture you've encountered? Oh, the fibula fracture is very tough because it's so thin, and there can be just a very thin line that sometimes the x-ray doesn't even pick up. So then you have to do it again in a couple weeks. Same with foot fractures. And then the last question that we can take today is how do you balance pain management and ankle fractures, especially considering concerns about opioid use? Oh yeah, so this is great. So there are better ways. So honestly, if they get osteopathic manipulative treatment right away, it usually helps their pain pretty significantly, so they don't need meds. But Tylenol is fine. For ankle fractures, NSAIDs are okay, like ibuprofen. It's just you don't want to do too much because you don't want to restrict the blood flow, which it can do. So they might be staying away from too much NSAIDs as well. But Tylenol plus osteopathic manipulative treatment is pretty good. And I think that's it. Janny, did you have anything else?
No, I think that's it. Great topic. Thank you all so much for joining. If you're not enrolled in ACT yet, we have a discount code for today running this week, webinar 400. Use that code at checkout for $400 off. Again, thank you all so much for joining. A link to the recording will be shared in a couple of hours. And please be on the lookout for the virtual shadowing certificate that can count towards your total experience hours if you're looking to apply for medical school, graduate school, and the like. So thank you all again and hope to see you at the next webinar.
Bye, guys. Oh.